Thank you guys. What a great day. So this is the last talk. Hopefully you all had a nice meal. Hopefully it won't put you to sleep. And then we'll come up and have a little Q&A session. If there's any question along the way, please let me know. So I've been asked to talk about, again, you've heard incredible things, new things, and now different positioning of the newer lines of therapy, the CAR-T, the bispecifics, the novel agents. And so we really are having this toolkit, and we just want it to be so big that we still have tools in, when we're called, that we still have several therapies that we never utilized. And so we just want to have that kit to be just full, chock full of options. So three things to kind of discuss today in my talk. One is the return to antibody drug conjugates. We'll talk about belantamab mafodotin or Blenrep. The new cell mods, which is sort of the new and improved fourth generation immune modulating drugs, and touch briefly on the attempt towards personalized therapy for every patient. So that's what we'll go over. So this is probably already seen today, but the timeline history of multiple myeloma and talking with patients again, first described in the 1800s, and the therapies on the bottom. Thankfully, we've come away from rhubarb and orange peel. And steel and quinine. But as you can see, we had very little things to offer. And again, talking with some of our transplant patients, when I talked to them about using melphalan, invented in 1958, that's still what we use. Surely we can do better over time, but it still has a huge role. Good old steroids in the 60s, dexamethasone. Most patients love-hate relationship with that. And then stem cell transplantation in the 80s, thalidomide coming out in 1999, the first immune modulating drug for multiple myeloma. And then you can see on the bottom there, Velcade, lenalidomide, and Pomalyst on the scene. And then you can see in 2015, the first monoclonal antibody, daratumumab and elotuzumab. Oral Velcade, ixazomib, Ninlero came out also as quite a year in 2015. So, and then, again, new first-line drugs, new and improved, just like everything. Thankfully, over time, we develop new drugs, new therapies, new and improved with less toxicity. So, scoot forward. So, that was up until about 2022, so it's like fast and furious, but you can see Dara came out in 2015, and then the first BCMA targeted antibody conjugate came out in 2020 with Blenrep. Subsequently, we'll talk about it, was taken off the market, hopefully to return, and then the first CAR-T product, after about 6 or 7 years of CAR-T for other indications, lymphomas, thankfully expanded into multiple myeloma. New isatuximab Sarclisa coming out in that same year, and the second CAR-T, Carvykti or Cilta-cel, came out in 2022. So lots of new things, and then of course the bispecifics, as you heard earlier today. Two that target the BCMA, the same as the Blenrep and the CAR-T and talquetamab, which is a novel target. So lots of novel therapies, thankfully, for this disease. So antibody drug conjugates. So what are antibodies? And kind of heard there's different types of antibodies, and you might hear about some are mouse-derived murine, some are human, fully humanized. Chimeric antibody was the first antibody. Rituximab came out a little over 20 years ago for B-cell malignancies. And for daratumumab was a fully humanized, and a lot of the antibodies that we utilize are fully human antibodies targeting various surface markers, so plasma cells. And then again, the bispecifics in the last 2 years. On the bottom, you see this antibody drug conjugate. That's what Blenrep is. And so essentially it's an antibody that targets plasma cells, BCMA, and attached to this antibody there is some drug, sort of a payload. I tell people it's like a delivery system, a delivery truck that can deliver toxin or radiation or whatever, but a chemo type drug in Blenrep. So at the bottom, that's sort of immunoconjugates. So you could conjugate, so the antibody can be conjugated with other things. And again, just think of it as like a delivery system, a delivery mechanism. So the antibody drug conjugate is what belantamab or Blenrep, which again came out in 2020. There are also radioconjugates where it attaches radiation, and that's been looked at in multiple myeloma as well. And you can see over there as the multi-step targeting is through CAR-T and through bispecifics. Naked antibody is more like isatuximab and daratumumab and elotuzumab. So their mechanism of action, we'll go directly into Blenrep. So this is, again, a humanized antibody. Again, it's an antibody that targets the cells that make antibodies, plasma cells in this case. And again, this B cell maturation antigen is something that's highly expressed on plasma cells, even higher on malignant plasma cells. And then conjugated to it is a toxin called MMAF, which is a type of toxin that disrupts sort of DNA replication. So again, kind of like a Trojan horse, it attaches to the plasma cell, and then it is internalized, releasing this toxin to then cause destruction of the myeloma cell. In addition, just by, and this is very similar to lone antibodies or naked antibodies like DARA, just by attaching itself, so kind of on the right side, just by attaching the other side of the antibody is your own immune system recognizes, kind of like it targets that cell as being a bad actor. So your own immune system cell, this effector cell, so that's that antibody-dependent cell cytotoxicity. So other cells can then latch onto the other end and immunologically sort of destroy whatever it's attached to. And so there's really kind of two mechanisms of action. One is the toxin reaction, but also just by attaching to it, it induces an immune response. So the initial approval, these are the early phase, the DREAM studies for belantamab for relapsed refractory multiple myeloma. And you can see there the DREAM 1 study, sort of phase 1 is always the dose finding study. And so you can see the inclusion, progressive disease after transplant, chemo, proteasome inhibitor like a Velcade and IMiD, and overall response rate in a fairly heavily pretreated patient population was about 60%. It led to a phase 2 study, 1-2 study, that ultimately led to the dosing of the 2.5 per kg every 3 weeks. A large 223 patients, greater than or equal to 3 lines of therapy. The median prior line of therapy was 7. So people have had 7 lines of therapy up until on average. And then, so the overall response rate varied depending on the dosing and the trial, but 30 up to 50% response rate in very refractory patient population. And that sort of, it was ongoing, the phase 3, DREAM 3 study, actually they moved forward with that and they compared the Blenrep to pomalidomide dex as their standard of arm for patients that had progressed, and that inclusion was greater than 2 lines of therapy. And so as part of the FDA approval in 2020 was sort of contingent on follow-up on the phase 3 study, which ultimately led to statistically favored some increased response rate and progression-free survival advantage, but it wasn't statistically significant. And so therefore it was halted in 2022 and was sort of voluntarily taken off the market by the company so that can sort of rethink different combinations, and we'll talk about that. But it was based on that phase 3 study that they took it off the market. We'll talk about it, but one of the biggest, 2 things. One is it's been, clinically, it's actually been incredible. This is prior to any other BCMA targeted, which is now CAR T and bispecifics, but we had significant responses in some of our patients, and if a patient was clinically benefiting, they were allowed to stay on it as part of sort of a compassionate use trial. And so we still have some patients that are still getting Blenrep, even though it's not available for a new start. But if a patient's been on it and was benefiting, they can stay on it. And so temporarily it's been taken off the market. So there's 2 studies that are likely to be submitted to the FDA soon, in the next few months. The DREAM-8 study, which looks at Blenrep, this, again, conjugated antibody plus pomalidomide and dex, versus the combination of Velcade Pom dex. Again, sort of relapse refractory patient population, equally randomized 1-to-1 between the Blenrep Pom dex versus a Velcade Pom dex, and a median follow-up of 21 months, and treatment continued until progressive disease or toxicity. And we'll get to it, but one of the things that we learned, and anytime there's a novel therapy, and kind of sometimes learn very rapidly and have to, one of the biggest limiting side effects of the Blenrep is ocular toxicity, blurred vision, keratopathy, dry eyes, can be significant and severe, typically overwhelmingly reversible, but as part of the sort of REMS program, patients are required to see an ophthalmologist prior to each dosing, but oftentimes with dose delays and dose modifications, it can be manageable, but that's one of its unique side effects, not totally clear as to why that our eyes are potentially affected by that. But again, in this randomized study, so Blenrep Pom dex versus Pom Velcade dex, you can see the median progression-free survival was not reached at 21 months in that combination versus about 12 months. And so it statistically significant improvement in the progression-free survival and sort of a trend towards an overall survival early analysis. But so many other options, it's always hard to really show overall survival advantage with all the options. But it did appear in this particular study that even in sort of this high-risk patient population, adverse cytogenetics, patients with extramedullary disease outside of our bone marrow, outside of the bone marrow, that patients seem to favor and have responses. These are patients that had had prior exposure to, obviously, to lenalidomide, Revlimid refractory, and also CD38 treatments, DARA, most likely. So overall adverse events, you can see, again, patients ultimately were on Blenrep arm longer, and so they try to kind of standardize based on how long a person is sort of on it. As you can see, like grade 3, 4, so that's the more extreme adverse events, were higher percentage-wise in the patients receiving Blenrep. But if you look at as to how long each person sort of, it's like per patient 100 year, that exposure adjusted events, it actually was very similar between the two. It's just that people were on the Blenrep arm longer, and so therefore the longer you're on something, potentially the more adverse events can be seen. So they try to standardize it. But then overwhelmingly sort of there on the third line, any ocular event leading to treatment interruption or delay, again, really not heard of significantly in the Pom Velcade dex, whereas 91% of the patients on the Blenrep arm had to be adjusted. But again, oftentimes these ocular events were manageable with holding the drug, dose modifications. A little bit more cytopenias, but again, overwhelmingly, it was the biggest separator was the ocular events and a little more infectious complications. Perhaps, again, more effectively depleting B cells, hypogammaglobulinemia, the need for IVIG, which I think we talked about, y'all talked about earlier too. So the DREAM-7 is looking at Blenrep Velcade Dex versus Dara Velcade Dex, and that's sort of the outline there. And the same kind of bottom line is looking at progression-free, but secondary looking at overall survival. And again, favoring the combination of belantamab plus Velcade Dex over Dara Velcade Dex, and some early overall survival suggesting an improvement, but too early to say. And again, these included patients refractory overwhelmingly and with adverse cytogenetics. So these are early, assessments of these clinical trials that are ongoing. Safety-wise, again, very similar as to the other combinations. Didn't seem to affect the toxicity of the other drugs by themselves as compared to what we're used to, or change the pharmacokinetics of the other standard drugs being used when combined with Blenrep. So ongoing studies, there's DREAM-5 study looking at Blenrep monotherapy or in combination that's soon to be recruiting certain patient populations. We've had some patients with moderate to severe renal dysfunction that we've done sort of off study, but they're looking at using it in impaired renal function and also liver function, and then different dosing regimens. And kind of again, after our first use of it in some of our patients, we learned oftentimes by even starting at a lower dosage at a little longer interval, depending on the clinical circumstance, oftentimes much more manageable side effects. So comparing the antibody conjugates versus CAR-T versus bispecifics, again, off-the-shelf antibody, they're down at the pharmacy. Same with the bispecifics, as opposed to having to apherese and collect the T cells. The mechanism is similar, although the other two don't have the toxin payload delivery, and so it's not dependent on the T cell health. A lot of our patients, their T cells have been through significant therapy by the time, and that's why incorporating much earlier is sort of the next step. There's no real chemotherapy, no lymphocyte depleting, no steroids. It's often much more available. Outpatient, doesn't require center, cellular therapy like UT or Baylor. There's REMS program, that's the ocular, it does require that, and the ocular toxicities can be significant. But there are some patients that in general, if you look at the overall response rate, single agent, it's not the same level as you see with CAR-T and or bispecifics. And so for those highly refractory, more and more patients are getting exposed to Dara in the upfront setting. And so the response rate's fairly low by itself. And so kind of like a lot is, in general theme, if something works for a disease, when nothing else works, is to move it earlier and to look at novel combinations. And the antibody drug conjugates are basically given until progression. CAR-T is sort of one and done, and support, although the new looks at maintenance post-CAR-T, and then the bispecifics also are continuous. They're all expensive, unfortunately, but nothing new there, unfortunately. So probably in the next 6 months, 12 months, we'll hear more about the combination with Blenrep and Pomalyst and proteasome inhibitors earlier. So the cell mods. So this is this cereblon modulating agents. Okay, so bottom line is this is a group of drugs that are kind of the fourth generation. So thalidomide was first, Revlimid was second, pomalidomide is fourth, and now this is sort of the fourth generation of immune modulating drugs. I remember when thalidomide came out, we're still learning actually what it does. We didn't really know the mechanism of action. And so at least a big part of its activity is it modulates a variety of what we call transcription factors. And so part of cancer cells is that not necessarily that they're dividing too rapidly, it's just that they're not dying, they don't have an off switch. And so they have this increased production of these transcription factors to tell the cell to divide and to divide, to divide. So if you can interrupt that, if you can modulate that, then the cell can undergo sort of a natural cell death. And so this new class of drugs, these immune modulating drugs, are much more effective at binding and disrupting that production of these transcription factors. So ultimately it leads to what's called apoptosis, which is the off switch is sort of, life is about a birth and a death. And so cancer cells are immortal. And so these cells are able to undergo a natural cell death. So these class of drugs, significantly, they bind much more tightly to and disrupt the transcription of these growth signals. They also they stimulate your own immune response to then attack the malignant cells as well. So you see increased cytokine production. In general, they have, just in general terms, there's two that are kind of in the forefront. They're both oral. They're in a very similar fashion. They're given 3 weeks on, 1 week off. But in general, oftentimes less toxicity. So they're like more effective with less toxicity. So definitely a group of drugs that are going to come onto the scene, but also potentially might dethrone, just like rarely do we have a patient that's on thalidomide these days. We may get to where the lenalidomide and pomalidomide may be a thing of the past. So, and this is just a list of the immune modulating drugs that have been developed through the years, back in '99 with thalidomide first. But mezigdomide and iberdomide are the two that we'll talk about. So this is one particular study, so heavily pretreated, relapse refractory, like triple class refractory, so that means an immune modulating drug plus a proteasome inhibitor plus an anti-CD38, and the overall response rates, so overall response rate was about 26%, and again, sort of reminiscent of back in the days of relapse refractory myeloma when thalidomide came out as a single agent. About a third of the patients, 20-30% of the time, patients had a response. Although that's sort of the classic definition of response. Sort of the clinical benefit you could see was higher. That means that includes people with like stable disease. And there's also sort of this disease control response. So there's some times where people, like, ideally you want remission, you want complete remission, but sometimes if you can just have stable disease, that buys time until you can get onto perhaps another therapy, like a bridging therapy. So definitely in highly refractory, essentially single agent iberdomide, and the same was looked at mezigdomide plus dex, and seemingly, again, it's not sort of obviously in direct comparison, but perhaps a better response rate, about 40% of the time. Patients overall, all patients had a response. So a bit more toxic, a little bit more toxicity, cytopenias, but in general, two classes of drugs, and including kind of high-risk patients, including patients that have had extramedullary disease, soft tissue disease outside of the marrow. So a couple of trials. This looks at iberdomide. So there's interesting laboratory data looking at combination of these cell mods with anti-CD38, but also proteasome inhibitors, that there's definitely a significant synergy between those, the cell mods and those classes of drugs. So it's sort of a background. So this is looking at iberdomide by itself, plus dex, plus dara, plus Velcade, and then also plus Kyprolis. So these are sort of ongoing studies that are being performed. Sort of the typical highly pretreated patient population, most prior transplants, often triple class refractory. And you can look at sort of some of the other descriptions of the two classes there, dose modifications, toxicities, mostly heme toxicities, most of them fairly manageable, but definitely neutropenia, very similar to what we see to some degree with, with the other immune modulating drugs, Revlimid and Pomalyst. So lots of things, but no evidence of clotting, whereas the other immune modulating drugs, Revlimid, Pomalyst, lutamide, we know can be associated with DVT. So overall response rate, so heavily pretreated patient population, about 42% overall response rate combined with iberdomide plus DARA and Dex, and then iberdomide plus Velcade Dex. So response rate was 60% in combination. And kind of going forward, probably the combination with Kyprolis is looking very promising, that combination. So you could see there, high response rate, heavily exposed patients, multiple class refractory, and again, no real effect in the pharmacodynamics of the DARA when it's used in combination. And this is just another look at the combinations, and we'll skip on. So these are some of this ongoing studies for patients that are undergoing, again, Iber-DARA versus DARA-Velcade Dex. As you see there at the bottom, looking at progression-free. Next, in 2026 is estimated completion. And then you could see there for relapse refractory, the combination with mezigdomide, Velcade Dex versus Pom Velcade Dex, and then the mezigdomide Kyprolis Dex versus Kyprolis. So there's ongoing sort of phase 3 studies looking at sort of the combination therapy of kind of the fourth generation immune modulating drug in combination with proteasome inhibitors and CD38. Additional looks, again, kind of post-transplant is a maintenance, randomized versus Revlimid is a maintenance. So that's ongoing right now. And then you can see very complex combination therapy there in the upfront. So that's going to take some time, estimated finish in 2027, but that middle slide. So Sarclisa, Rev, Velcade Dex versus RVD, which is fairly standard, although you might argue it's maybe outdated at this point. And then versus ISA plus iberdomide, Velcade Dex. And then there's another study ongoing looking at sort of MRD driven. And so for those patients that were MRD positive, randomly assigning to a second transplant versus a second transplant followed by consolidation, followed by a cell mod as part of their maintenance. So lastly, sort of personalized therapy. And again, it's very difficult with each individual. As you know, and you hear, it's very complex disease, heterogeneous, and it's always evolving. And so it's, we talked earlier about some of the cytogenetic abnormalities that these things can change over time. And so the disease itself evolves over time, and so it's this moving target. So not only is it personalized for each patient, individualized, but that therapy has to be able to make changes as the disease course changes. And so some of the things that we think about, like when we see patients up front, to try to come up with a treatment strategy, just not one size fits all. We look at obviously the patient's age, look at their overall health status, other comorbidities, other issues, how advanced their disease is, and talking about sort of cytogenetic and molecular abnormalities, skeletal disease. We know people with extramedullary disease often have a much more aggressive course, plasma cell leukemia, and then of course renal dysfunction associated with the myeloma factors in. Some of the high-risk cytogenetics listed there, kind of the classic is the deletion of 17p, but there are also 414, 1416. These are translocations between two sets of chromosomes that, again, that list there often translate to a more aggressive course and a higher risk of or shorter remissions and overall shorter survival. So, And then other clinical presentation, high-risk disease markers, again, some laboratory surrogate markers, circulating plasma cells, and extramedullary sites. So, as we would all say, obviously you want to discuss this with your physician. Everyone is treated differently. I tell you, with multiple myeloma, it presents multiple ways. It's ever evolving. It's changing within each one. There are some patients that, more and more we're picking up this early, smoldering myeloma. Again, if a patient has the so-called CRAB criteria and or the slim CRAB criteria, so if they need therapy, we treat as active. And for those patients that have what we call smoldering myeloma, there's different strategies for people that we feel like are higher risk, and there are some newer molecular studies that are being looked at to try to predict their likelihood of going into multiple myeloma. And so there's ongoing studies and off studies efforts to try to postpone the progression to myeloma. For those patients with active myeloma, sort of standard versus high risk, still the standard induction, RVD, consider early transplant versus potential delayed transplant. And now more and more, the standard would be to offer some post-transplant maintenance and lenalidomide's the standard. For those kind of with high-risk disease, adverse cytogenetics, often the combination, and now more and more, even in the standard risk, I think we often recommend the combination of anti-CD38 DARA or isatuximab with RVD, and then consider the early transplant. And then in high-risk cytogenetics, we think of the proteasome inhibitors being active more so for that class of diseases, and so often like to combine with the proteasome inhibitor post-transplant. And then for transplant ineligible, sorry, sort of cut off, but DARA, Revlimid Dex, DARA, RVD, Sarclisa RVD, recently FDA approved for transplant ineligible patients. So, and then in general, the idea would be then the patient would maintain on some version of that until disease progression. So, Lin not available really is not a huge, we don't have thalidomide Revlimid's generally available everywhere, but for renal failure, a little tricky with immune modulating drugs. And so oftentimes a combination of Velcade, DARA Velcade, plus or minus chemo. And then for those patients with high grade plasma cell leukemia, oftentimes we favor a chemo-based. So very complicated, like lots of different algorithms. And in interest of time, we'll have these slides, but there's not one size fits all. And hopefully over time, as we're getting sort of more understanding on some of the underlying mechanisms, we can have, sort of a more targeted therapy, and that's being looked at ongoing. So, and as we heard earlier today, bispecifics CAR-T, again, if it works as fifth line, then why wait to fifth line? Moved up second line, third line in certain circumstances. So I think that's it. Sorry, a little late. Thank you.